Thank you. Thank you, Mark, for the invitation. Not sure I should say thank you because I had a lot of anxiety for several months. And anxiety just getting worse and worse as the deadline was approaching because I'm a geriatrician. I was trained in chronic pain and palliative care, and I work in pain clinics for older people. And I got interested in cannabis by necessity more than interest because people keep asking about it like 10 times a day, even when they're old. So Mark asked me to present on that, and then I realized I had nothing to say. So I was trying to figure out how I would... Yeah. So I was trying to think of ways to stand up here for 30 minutes not saying anything. And then a paper came out in March 2018, which saved my life. Because I thought I would talk to you about like my 25 patients on cannabis, but this would have been pretty boring. Okay, so cannabinoids in older person, and I also asked for permission from Mark to talk about synthetic cannabinoids, which we haven't heard much about today. So first gonna talk a little about I'm gonna tell you in a few minutes that there will be more and more older people. So a spoiler, do they use cannabis? How does the endocannabinoid system change with age? Not sure if they talked about that this morning in the first session because I fell asleep at the wrong gate at the Montreal airport, didn't hear my name called 3 times and missed the flight. So I missed the Cannabis 101 talk, so sorry if they talked about that already. So, so can we reverse that? And then I'm gonna summarize the evidence on synthetic cannabinoids in older people, which I'm gonna do right now because there's no data. There is no specific data on the use of synthetic cannabinoids in older people. Of course, there are studies, but none of these studies have isolated the older subjects, so we don't know anything about these. Then medical cannabis, this is the study that saved my life. And then some very interesting animal studies on cannabis or memory in Alzheimer's disease. So this is Quebec, but I think Canada is pretty much the same. It's a little less striking in Canada than in Quebec, but still we see that there will be more and more older people. We see the green region, the green area there are the baby boomers, the ones that were born just after World War II, and these people are getting older, as we see. So this is now, and they will keep getting older. So why are we interested in these people? For a few reasons. First, because there are more and more of them, as you can see, and also because they were the ones who were teenagers or young in the 1960s and 1970s. And you know what happened in the 1960s and 1970s. So knowing that, we're not surprised that cannabis use is increasing in older people. Older here is defined as 50. I think this is debatable. But that's how they define that. We usually say old is 10 years older than you are. So as we get older, old just gets older too. So people 50 years and older just keep using more and more cannabis since 2002. And we can predict that this is just gonna get even more because there will be more older people and they will have more chronic diseases because people live longer, but they don't live longer in better health. They live longer in a poor health, mostly because of chronic pain and disability. And because chronic pain is one of the reasons that people use cannabis, we can expect that people will use more and more cannabis, and also the recreational. My parents, who are 75 and they're like friends group, they're really waiting for legalization. So cannabis use in older persons. So, oh, now I see that I don't see that. That's too small. Sorry. So we see that there are more and more people using cannabis. I'm going to try to read that, but I'm afraid I won't be able because that's too small. So I think the first red rectangle says that what does it say? See. 1 year prevalence, yes, 1 year prevalence of the use of cannabis in older people. This was a study done in the United States, and the one-year prevalence was 2.7% for the cannabis use in older people. I see people nodding that I did read this well. It was used more by people who were 50 to 64 rather than people who were 64 and older. And having a major depressive disorder was a risk factor for using cannabis. We can also see that in this population, the cannabis use disorder was only diagnosed in 0.12% of the population. And 4.52% of those who said they used cannabis in the past year were diagnosed with a cannabis use disorder. I'm not going to try to read this one. What this one says is that the cannabis use disorder is still a little higher in this study than in the previous study, but it's still fairly frequent in older people. And the alcohol use disorder is also common in these people. There are some studies showing that anxiety is a risk factor for using cannabis in older people, as we can expect, as was depression in the previous one. So this is the study that saved my life in March 2018. This one was a retrospective study on epidemiology, safety, and efficacy of medical cannabis in the elderly. So this one was done in the UK, and they just asked people about if they used cannabis in the year before, and then they tried to correlate that with a few variables. I said at the beginning that I became interested in that by necessity, and I think that it's probably 1 out of 2 of my patients who is asking about cannabis these days. And if it's not the patient, it's the children or the grandchildren. So it's a topic that's very often brought by patients. And just this morning, there was a paper in the Daily Mail in the UK saying that 70% of older people consider using cannabis to treat their chronic pain, just because they think that it's safer and that it's more effective than using opioids. Is it? Not clear, I would say, but a lot of people think that. So what they showed in that study, where they studied the use of medical cannabis in older people, is that, well, first, most people were like in 65 to 74 years old, more male than female, and 34% of these people had used cannabis after they were 65 years old. So the other ones started using it when they were younger. The main reason for using cannabis was the cancer-associated pain or neuropathic pain, so nothing surprising here. This is a table where they tried to tell us which strain they used. Was it indica or sativa? And there was nothing interesting there, because it's kind of all around the place. So you can try to see if you find something interesting to say about that, but I didn't find anything interesting. And I tried to add up the percentages, but it added up to 150%, so I gave up. So does it work? So we see that quite a few people use it, and does it work? Because what we've been hearing all day, right, is that there is no evidence showing that it works. And that's what I always tell patients also, that yeah, we can try, but there is no evidence that it works. So I would say this is the first study. It's not an RCT, but this is the first study that suggests that there is some analgesic efficacy of medical cannabis in older people. So we see that the median pain intensity went from 8 out of 10 to 4 out of 10 in people who were using it. Of course, that's not randomized, so we have to take this with a grain of salt, but that's what they saw. And the severe pain went down from 67% to 7.6%. So this is quite significant. This is much better than what we see in the opioids studies. And quality of life. At the beginning of the study, 14% of these people said they had a good or very good quality of life. And at the end, 59% said that the quality of life was good or very good. So this is also very significant. And the bad or very bad quality of life went from 63 to 16%. So this is very good evidence that it seems to work. The perception of the general effect of the cannabis after 6 months, because the study was a 6-month duration, 94% said that they were slightly, moderately, or significantly improved, and 42% said that they were significantly better at the end of the 6 months using medical cannabis. And also, 35% reduced the number or the dose of the other drugs that they were using. So this is also a very interesting data there. Side effects, because that's what we're concerned about, right? When we talk about old people using cannabis, 32% reported side effects. Of course, there's no placebo, so we can't compare with the placebo. But there were no serious side effects reported by people. 18% had to stop the cannabis, 1.6% because it wasn't working, and only 1.4% because of side effects. So that's a very, very small number. And the number of falls, this is very surprising. People who had 1 or more falls in the past 6 months went down, because that's what we're afraid of with the cannabis, mainly with the THC. So 53% had fallen, and then after the 6 months on cannabis, it went down to 22%. Maybe they were just too sleepy and they spent all day in bed. But apparently not, because their quality of life was better. So for some reason, they seem to fall less. Maybe they are flying rather than walking. So why would it work? This is something very interesting, that the age-related changes in the endocannabinoid system. So there are a lot of very interesting studies done in rats. So we see that when they study old rats compared to young rats or mature rats, they see that the CB1 mRNA levels or the specific binding of the CB1 agonist in the brain peaks at puberty, then it stays at a stable high level in adult life, and then it decreases in late life, mostly in the cerebellum, the cortex, the hippocampus, and the hypothalamic structures. And we should remember about the hippocampus, because that's where the memory is, and that's when we're going to talk about the memory later. We also see that there's a decreased receptor availability, and that this is likely due to post-transcriptional mechanisms. There's a decreased coupling of the CB1 receptors to the G proteins in some brain areas. And something very interesting is that when they knock out the CB1 receptors in young animals, they see that their learning and their memory tasks gets better. But when you do that in old animals, it gets worse. So we're going to talk about that later, but it's like there's some kind of a downregulation of the endocannabinoid system when people get older. So if you supplement them with cannabinoids, then it brings them back to their younger years. So this is one of the hypotheses. So in humans, the CB1 receptor levels are much higher in younger than older individuals. There's a 50% decrease in the CB1 mRNA levels in the older humans. The mRNA levels of the endocannabinoids, biosynthetic and metabolic enzymes, change differently with aging. Some are decreasing and some are remaining stable. We don't know if this is correlating with endocannabinoid levels. What we know, though, is that the age-related changes in the expression of the components of the endocannabinoid system, there are changes in both rodents and humans. So the endocannabinoid system doesn't stay stable with age. It seems to be impaired with aging. We see here that the endocannabinoid systems are involved in several areas of the brain mechanisms that are impaired with aging. So they are involved in the mitochondrial dysfunction, which is one of the hypotheses of Alzheimer's disease, which we're going to talk about later. They're involved in the cerebellum. They're involved in the post-transcriptional mechanisms. So the endocannabinoid system seems to be involved in a lot of the mechanisms of aging. So what do we do from now? So they try to give THC to old mice. So what I wanted to do is to see if prolonged exposure to a low dose THC would have long-lasting effects on learning and memory performance in young mice, mature mice, or old mice, the old mice being 18 months. So they gave them osmotic mini pumps that they implanted, and these pumps released 3 milligrams per kilo body weight per day of THC, and there was a placebo group just using a vehicle, which did not deliver any drug. The assessment started at day 33, so that there was a 5-day washout between the last day of the pump and the first day of assessment. So what they saw is, and the test that they used was the Morris water maze test. So the mouse has to swim in the maze and try to find its way back, or trying to find where something is placed. And when you do it several times, you should remember, and you should be faster, or you should spend more time in one specific area. So that's what they tried to do, and that's the measure they used. So what they showed is that the mature and the old mice learned the task more slowly. So this is what we expect, because there is a decrease in the spatial learning and the spatial memory when we get older. What is very interesting, though, is that the THC improved the task recognition in the mature and old mice. And this was persistent even in the reversal phase, so when they did it later. So this is a marker of learning flexibility. In the young mice, though, as you see on the left graph, there was no effect of the THC. So the effect was only in the mature and even more in the old mice. And then they did the probe trial phase on day 6. This is a marker of long-term spatial memory. So the young mice performed worse. We also know that from human studies that THC can impair memory in young people, but the old mice, the THC improved the memory to the level of the young controls. So if you supplement the endocannabinoid system of the old people to put them back as they were in the younger age, the memory seemed also to get better. And then they did another test, which is a marker of long-term spatial memory. And what they showed, and this is a novel object location recognition test, so that they put an object in the maze, and the mouse has to remember where the object is. And when they do that several times, they study how long they spend in one specific area where the object is. So they also showed that the THC abolished the cognitive deficit that is related to age. So the old mice performed just the same way that a young mice did. And then a partner recognition test that they put another mouse in the maze. Sometimes it's the same, they use the same mouse twice, and apparently the mouse recognizes the partner. So if it recognizes the partner, it performs better because it feels better to have a friend with him. But if it's a new mouse, it doesn't perform better. So what they showed in that, and this is a marker of long-term memory, is that THC improved the partner recognition memory. So the THC seems to abolish the cognitive deficits associated with age. We also have studies on the effect of the THC on the synaptic density of the hippocampus. So they eventually killed the mice and they studied their hippocampus. And they showed that the THC increased the synapsin 1 and the synaptophysin levels in the mature mice to the level of the young mice. They showed that the THC increased the hippocampal spine density, and that there was also a difference in the gene expression profiles. So the THC-treated mature mice had a gene expression profile that was similar to the young mice, and the THC-treated young mice had a gene expression profile that was similar to the mature controlled mice, so the one that didn't have the THC. So this is a suggestion that the THC might be detrimental in young mice, but beneficial in the mature or the old mice. So replacing restoring the CB1 signaling might be a good strategy to treat the age-related cognitive impairments. So moving on to Alzheimer's. This is the Alzheimer's disease pathophysiology. So there are lots of debates on the pathophysiology of Alzheimer's, and people are arguing about it. But the two main hypotheses are that there are two distinct mechanisms. One is the hypophosphorylated tau, the tau protein, which gives neurofibrillary tangles. And there's the accumulation of amyloid beta. The square here should be beta protein. So this is generated by aberrant processing of the amyloid precursor protein. And the abnormal protein accumulates in various regions of the brain, mainly the hippocampus, the prefrontal cortex, and the amygdala, so which are the regions that are responsible for memory. So these are the two hallmarks of Alzheimer's disease. And what causes that? Neuroinflammation and oxidative stress is one of the main reasons causing that, and it eventually leads to cognitive decline and behavioral changes. And mitochondrial dysfunction, which will also at some point lead to neuronal death and cognitive deficits. So what we know, again, mostly from rodent studies, is that some endogenous cannabinoids can activate the CB1 receptor and the mitogen-activated PK pathways, which are regulators of the cell function. And there's then concentration-dependent inhibition of the amyloid beta neurotoxicity. We also know that administration of the potent cannabinoid reuptake inhibitor can improve the amyloid beta-induced neuronal damage and memory impairment. It can have positive effects if it's administered early. So this suggests that early pharmacological enhancement of the brain cannabinoid levels may protect against the amyloid beta neurotoxicity. In another study, they administered synthetic cannabinoid in the ventricles, several ventricles, and they showed that it prevented amyloid beta-induced microglial activation. It prevented the cognitive impairment and the loss of neuronal markers. So what this suggests, again, is that the cannabinoid receptors are important in the pathology of Alzheimer's disease, and the cannabinoids can prevent the neurodegenerative process. CBD can inhibit in vivo A-beta plaque formation. It can decrease the ROS production and lipid peroxidation. And the end result of all this is that the CBD can reduce the formation of both the amyloid plaques and the neurofibrillary tangles. Another study with CBD and another cannabinoid showed that it can improve the learning behavior of mice when they're injected with amyloid beta. THC has been shown to inhibit the acetylcholinesterase, and the main treatment we have now for Alzheimer's disease is a symptomatic treatment. So we give the cholinesterase inhibitors to try to increase the level of the cholinesterase, and THC can actually prevent the acetylcholinesterase-induced amyloid beta aggregation, and it's in the studies, it was even more effective than the acetylcholinesterase inhibitors, which is the best treatment we now have for Alzheimer's disease. Another study that was kind of similar with a combination of THC and CBD. But there are no population-based studies. All these studies were done in mice or rats. What's the safety of the cannabinoids in Alzheimer's disease? Could it increase the confusion? We also know that the cannabinoids can increase the risk of psychiatric disorders and psychosis, especially in those who are already vulnerable. So maybe it could put people with Alzheimer's disease in psychosis. So we don't know. There are no human or population-based studies. What we do have now, just to conclude, is quite a few studies on the effects of neuropsychiatric symptoms. So we know that people who have Alzheimer's disease, especially at end stage, often get agitated. They stop to eat. So they did a placebo-controlled crossover study. Each period was 6 weeks. People had Alzheimer's disease that had stopped eating. They gave them dronabinol 2.5 milligram BID. And it decreased the anorexia, the weight increased, the tricep skin fold increased. So it seems to have reversed some of the anorexia and the refusal to eat. And also there was a decreased agitation in these people. Another one where they gave THC for nighttime agitation in severe dementia. This one was an open label study. It was just a pilot study. We can see here that the effect in the number of agitation episodes was significant. People were less agitated with the THC. They tried to do the RCT, but they couldn't recruit, so they had to stop. And I think this is the last one where they studied dronabinol for the treatment of agitation and aggression in people with severe dementia who were admitted to the hospital for behavioral symptoms. It was a retrospective chart review. People with Alzheimer's disease treated with dronabinol for behavioral appetite disturbances. They were treated for 4 to 50 days. Mean dose was 7 milligrams a day, and it decreased agitation. It didn't increase body weight, and it didn't decrease the number of the psychoactive medications, but there was a decreased agitation with the dronabinol. So in summary, cannabis use is increasing in older people, as we said. Very few people, older people have a cannabis use disorder. The medical cannabis seems to reduce pain, improve quality of life, and reduce use of other analgesics without serious adverse effects. There is no age-specific data on synthetic cannabinoids. The rodent studies suggest that the cannabinoids can prevent the age-related cognitive decline, and the cannabinoids could prevent or reverse cognitive decline and neuropsychiatric symptoms in Alzheimer's disease, either via direct action or on the physiopathology of Alzheimer's disease. And just a little clinical note, because I've been using or authorizing medical cannabis in my patients, as I said, maybe 25 of them, which is not that many, but still. And it's not easy because these people are used to take medications, right? More than taking cannabis. So they really need direct instructions on how to do it. And so we have to tell them exactly how to use it. And we have to tell, well, then you use 0.25 or 0.5 cc's for 3 days, then you increase, and then you switch. So they have a hard time even with these directions, like figuring out how to use it because they used to have their pills in the pill box. So I think this is just an argument that we really need to keep the medical use separate because I don't see my patients like going to a store to get their cannabis because they would get mixed up, I think.
Thank you, David.